Hello again and welcome to another microbiology lecture on gram-positive cocci. So gram-positive cocci are spherically shaped bacteria that are common residents in the mouth, the gastrointestinal tract, the genitourinary tract, and the skin surface. So the most important genera are Staphylococcus, Streptococcus, and Enterococcus. So these are among the most common bacteria implicated in disease. We will be talking about their specific structures, their virulence, meaning how they are able to avoid the immune system of the host and how they can cause disease. Okay, for example, by adhesion and invasion of tissues and production of toxins and hydrolytic enzymes. But although they are implicated in disease, it's important to remember that these are common residents on the human body. Okay? So let's start with the Staphylococci. Again, these are gram-positive cocci that tend to be arranged in irregular, grape-like clusters. No? But sometimes they can appear in short chains and pairs also. So it is a common inhabitant of the skin and mucous membranes, and it accounts for a considerable proportion of human infections, often called staph infections. Currently, there are around 45 to 47 species, but we will be talking about the most important human pathogens only. Okay, so Staphylococcus aureus and the other coagulase negative staph or the cons. You have staph epidermidis, which causes around 75% of cons infections, and staph saprophyticus, another common cause of UTI, which we will learn more about in a while. So these are the coagulase negative staph. Okay, of these three, staph aureus is by far the most common and it causes the most serious infections. Okay, so Staphylococcus aureus is considered the most serious pathogen. So it is non-motile, it does not form spores, it produces round, opaque to white colonies that tend to turn buff golden in color, no, with time. So that's why it's called aureus. So it is a facultative anaerobe, meaning it can make energy by aerobic respiration if oxygen is present, but it is capable of switching to fermentation or anaerobic respiration if there is no oxygen available. Okay, so let's discuss the important properties of the bacteria. First, the cell wall. So the cell wall of Staph aureus consists of a typical gram-positive peptidoglycan. No? I remember the thick interlinked polysaccharides, the NAM and NAG with the tetrapeptide interbridges. Okay. So this provides a rigid exoskeleton for protection. And it is also important in the pathogenesis of infection because the cell wall has endotoxin-like properties. No, that is, it can stimulate macrophages to produce cytokines, and it can activate the complement and coagulation cascades. Okay, so this explains the ability of Staph aureus to cause the clinical manifestations of septic shock, no, even without producing endotoxin. So it is commonly overlaid with polysaccharide and surface proteins or adhesins that mediate adherence of the bacteria to host tissues. No? So you have protein A. This is one of the proteins. In fact, it is the major protein found in the cell wall of Staph aureus. It is an important virulence factor because it binds to a portion of the antibody or the immunoglobulin G, particularly the Fc portion of IgG molecules, except IgG3. Okay, at the complement binding site. Okay, so this prevents activation of the complement system. Now, protein A is an adhesin. No? It is part of a group of adhesins called microbial surface components recognizing adhesive matrix molecules or MSCRAMs. Okay? And also remember the teichoic and the lipoteichoic acids. No? These are polymers of ribitol phosphate. They mediate adherence of the Staphylococci to mucosal cells. So the lipoteichoic acids play a role in the induction of septic shock by inducing cytokines, no, such as interleukin 1 and tumor necrosis factor from macrophages. Another important MSCRAM is clumping factor. This is present also on the cell wall surface. So, clumping factor binds non-enzymatically to fibrinogen and platelets, producing aggregation of the bacteria. So, it causes the adherence of the bacteria to fibrinogen and fibrin. So, the fibrin clots hide the bacteria from phagocytic cells. Now, polysaccharide capsules are present in most strains of Staph aureus. These capsules are considered to be an important virulence factor because they are anti-phagocytic and they increase the virulence in animal models. There are 11 serotypes based on the antigenicity of the capsular polysaccharide, but types 5 and 8 cause majority of the infections, no, mga 85% of the infections. Now, the capsule is poorly immunogenic, meaning it does not cause an immune response in the body of the host, no, which has made producing an effective vaccine very difficult. Staph aureus also produces a number of enzymes and toxins. Okay, so all Staphylococci produce catalase. So this is what differentiates them from Streptococci. So catalase degrades hydrogen peroxide into oxygen and water. This is an important virulence factor because bacteria that make catalase are able to survive the killing effect of hydrogen peroxide in neutrophils. No? We will discuss the catalase test procedure in a separate video. Staph aureus is distinguished from other Staphylococci by their ability to produce coagulase. Okay, so coagulase is another enzyme that is produced by Staph aureus that causes plasma to clot by activating prothrombin to form thrombin. No? If you remember your coagulation cascade, thrombin, it then catalyzes the activation of fibrinogen to form the fibrin clot. No? So this is not present in Staph epidermidis and saprophyticus. Coagulase may also deposit fibrin on the surface of staph, no? And protect the staph from ingestion by phagocytic cells or prevent destruction within the phagocytic cells if they are indeed ingested. The adherence to the clots formed are then enhanced by clumping factor, which we discussed earlier. That's why in other books, clumping factor is also called bound coagulase. No? And the coagulase enzyme is called free coagulase. By the way, we will talk about the coagulase test procedure in another video also. Staph aureus also produces staphyloxanthin. This is a carotenoid pigment that gives the colonies its golden color. So again, this is why it is called aureus. This pigment actually enhances the pathogenicity of staph by inactivating the microbicidal effect of superoxides and other reactive oxygen species, or ROS, produced by the neutrophils. So this is not produced by staph epidermidis, no? That's why they only produce white colonies, not gold. And also maybe that is why they are even less virulent than Staph aureus. Staph aureus also produces hyaluronidase, or the spreading factor. This is an enzyme that appears to promote invasion by digesting the intercellular glue, or hyaluronic acid, that binds connective tissue in host tissues. No? Staph aureus also produces four hemolysins. So you have alpha hemolysin, or alpha toxin. This is considered the most important in terms of biological effect. So alpha toxin is a pore-forming cytotoxin that lyses the cytoplasmic membranes by direct insertion into the lipid bilayer of host cells, no, to form transmembrane pores. Now, this causes leakage of low molecular weight cell contents and, of course, cell death. It lyses RBCs, no, even renal tissue, even skeletal and heart muscle. Beta toxin is another hemolysin. It degrades sphingomyelin, and it is toxic to many kinds of cells also, including RBCs. Delta toxin also disrupts biologic membranes, no? And it is believed to play a role in the Staph aureus diarrheal diseases. And you also have gamma toxin. So this is a leucocidin that lyses WBCs, and this gamma toxin can also interact with another toxin called the Panton-Valentine leucocidin, or PVL. Now, PVL is also a pore-forming toxin that kills cells, especially white blood cells. That's why it's called leucocidin, no? By assembling in the cell membrane to form pores, causing cell contents to leak out of the WBC. The PVL gene is encoded on a lysogenic phage. This is also considered an important virulence factor for community-acquired methicillin-resistant Staph aureus infections, or MRSA infections, no? And severe skin and soft tissue infections. Now, the protein toxins formed from the interaction of the gamma toxin and PVL are capable of lysing WBCs by causing pore formation in the cell membranes, no? Leading to a massive release of inflammatory mediators like interleukin 8, leukotrienes, histamines, which are responsible for necrosis and severe inflammation. Staph aureus is also known to produce toxins known as superantigen toxins. No? Superantigens are a class of antigens that causes activation of T cells, resulting in excessive activation of the immune system, no? And massive release of cytokines. So one group of the superantigen toxins is the group of exfoliative toxins. No? So these are epidermolytic toxins. You have exfoliative toxin A and exfoliative toxin B. So exfoliative toxin A is heat stable. It is able to resist boiling for 20 minutes, and it is encoded on a phage. Okay? Exfoliative toxin B is heat labile, and it is plasmid mediated. Now, these toxins are again epidermolytic, no? So they act as a protease that cleaves desmoglein in the desmosomes, or intercellular junctions, and they dissolve the mucopolysaccharide matrix of the epidermis. No? This leads to the separation of the stratum granulosum, or the granular cell layer, from the stratum spinosum or the spinous layer, causing the skin to peel away in staphylococcal scalded skin syndrome or the SSSS. All right. Another important superantigen is the TSST or the toxic shock syndrome toxin 1. So TSST1 binds to major histocompatibility class or MHC class 2 molecules. No? Remember ang hanger ni Dr. Pilones na naipanti? So this causes stimulation of T cells, no? And then this promotes the manifestations of toxic shock syndrome, fever, shock, multi-system involvement, or even multi-organ failure. By the way, when we say shock, no, we do not mean emotional shock. This refers to shock that may manifest as hypotension and tachycardia. And we also have the enterotoxins. So these are heat stable and therefore they are not inactivated by brief cooking. And they are also resistant to stomach acid and enzymes in the stomach and jejunum. So they are important causes of food poisoning, no? Or staphylococcal food poisoning. When ingested, they stimulate the release of large amounts of interleukin-1 from macrophages and interleukin-2 from helper T cells. So these cytokines released from lymphoid cells, they will then stimulate the reflexes of the enteric nervous system and activate the vomiting center in the brain via the vagus nerve, no? Causing the vomiting manifestations of the disease. Now, how is Staphylococcus aureus transmitted? So humans are the reservoir for staphylococci. The nose, particularly the anterior nares, is the basic habitat or the main site of colonization of Staph aureus. Okay, the skin, especially of hospital personnel and of patients also, no, is also a common site of colonization. The bacteria are shed to the exposed skin and clothing of the carrier and also others, no, with whom they are in direct contact. Spread is augmented by touching the face and, of course, nose picking. And once it is present on the skin, Staph aureus can gain deeper access through skin appendages or trauma or breaks in the skin. The chief sources of infection are shedding human lesions and fomites contaminated from the lesions. Now let's talk about the spectrum of disease. It is actually surprising that a potentially very virulent bacterium like Staph aureus is a common and even a resident of the human body. Staph is present in most environments, no? And it is readily isolated from fomites and, like we mentioned earlier, in the anterior nostrils and to a lesser extent on the skin. Circumstances that predispose a person to infection include poor hygiene and nutrition, tissue injury, diabetes mellitus, and immunodeficiency states. Okay, the scope of staphylococcal disease can vary depending on the degree of the invasion or the production of toxins. No, from a localized skin infection to staphylococcal food poisoning, and even up to bacteremia and systemic dissemination and multi-organ involvement. Okay? Staph aureus usually invades the skin through wounds, follicles, or skin glands and cause primary infection. The most common infection is actually just a mild superficial inflammation of the hair follicles or folliculitis, or the glands, no, or hidradenitis. These lesions usually resolve without complications. but they may also progress to infection of the subcutaneous tissues, resulting in a furuncle or boil, and even an abscess or cellulitis, no? The boil mo ning usually ginatawag og matagtiki. Okay? Another form of cutaneous staph infection that is not confined to follicles and the skin glands is the bullous type of impetigo. Staph infection can also result from direct contamination of a wound, like post-operative or post-surgical infection, no, or infection after trauma. So usually, upon invasion of the bacteria, attachment is mediated by surface proteins. No, adhesion and further invasion then allow the staph to persist and produce alpha toxin and other cytolysins, no, which injure the cells. The lesions become destructive and they spread below the surface. At this stage, actions of coagulase and clotting factor on fibrinogen binding and the antiphagocytic effect of protein A binding to IgG, all of these combine to limit the effectiveness of host WBCs and phagocytes. The continued production of alpha toxin destroys keratinocytes, and not just keratinocytes, also other cells, including platelets, thus compromising repair and allowing the lesion to expand. The inflammatory cells, fibrin, and other tissue components then form a wall, no, which becomes the painful familiar boil, no, with pus formation in the center. When this progresses and expands and forms multiple compartments, you now call it a carbuncle. The infection can also spread to other sites, no, via the bloodstream. It can go deep to affect bone and muscle. That's what we call osteomyelitis. And because these bacteria inhabit the nasopharynx, when immunocompromised, for example, they can be aspirated to the lungs and cause a form of pneumonia. So it can cause pneumonia with lung abscesses. Okay? And it can also disseminate and cause bacteremia or the presence of bacteria in the blood. And of course, it can further reach other organs to cause endocarditis, meningitis, and other itis, no? Infecting other organs. Okay? Now, take note, these are all considered the pyogenic forms of diseases of Staphylococcus aureus infection. Okay? But Staph aureus can also cause toxin-mediated diseases. Food poisoning is caused by ingestion of enterotoxin that is pre-formed in food. Okay? And hence, it has a short incubation period, around 1 to 8 hours only. No? And in staph food poisoning, vomiting is typically more prominent than diarrhea. So this is associated with foods such as custards, sauces, cream pastries, processed meats, potato salad, or dressings that have been contaminated, no, during preparation, okay, and then left unrefrigerated for a few hours. Another toxin-mediated disease is toxic shock syndrome. This is characterized by sudden onset of fever, hypotension, and a diffuse macular sunburn-like rash that goes on to desquamate or peel, no? And the involvement of 3 or more of the following organs: the liver, the kidney, the GI tract, central nervous system, muscle, or blood. Okay? It can happen within 5 days after the onset of menses in ladies who use high absorbency tampons and do not change them immediately, no? And also in children and men with staph wound infections. Of course, wala man tampons ang children ug ang men, no? Now, why tampons? Around 15% of women have staph aureus in their vaginal flora, okay? And during menstruation, the relatively high protein level and pH in the vagina favor the acceleration of growth of these staphylococci. And of course, also the production of TSST1. The toxin can then be absorbed by the vagina and circulate to produce massive superantigen mediated cytokine release and shock. Neonates and children with staph aureus infection of the umbilical stump or the eyes are susceptible to a toxemia called SSSS, no? Or the staphylococcal scalded skin syndrome. Upon reaching the skin, the toxin induces a painful bright red flush over the entire body that first starts as blisters and then it causes peeling of the epidermis. No? Majority of cases happen under 4 years of age. Now, how do we diagnose? For diagnosis, we can use swabs or aspirates from an abscess, from blood, from an aspirate, or from sputum, or other bodily fluids, no, depending on the localization. Okay, you already know that the staph aureus will appear as gram-positive cocci in clusters, no, in smears. Of course, we cannot distinguish staph aureus from the other less pathogenic staphylococci on smears, no? So we will have to use another way. Another way is by doing a culture of the specimen on blood agar plates, no? Staph aureus produce typical colonies in 18 hours at 37 degrees Celsius. But hemolysis, which is beta hemolysis, and the production of pigment, particularly the golden pigment formation, they may not occur until several days later pa. Okay? Mannitol salt agar is a commonly used screening device for staph aureus. Staphylococcus aureus ferments mannitol, no? Which lowers the pH. This causes the agar to turn yellow, whereas ang other staph, they will not ferment mannitol and the agar will remain pink. The catalase test is used to differentiate staphylococci from streptococci. Okay? Positive result is the formation of bubbles, no? And if there is formation of bubbles after the test, it means the bacteria are staphylococci. The coagulase test is used to differentiate staph aureus from the other staphylococci. Okay, so what you need to know is that Staphylococcus aureus will show a positive coagulase test result, which is the formation of clots. Susceptibility testing of Staphylococcus aureus is used to determine antibiotic susceptibility, no, and resistance, and therefore it's used for treatment, but it does not aid in the diagnosis. In toxic shock, for example, toxic shock syndrome, isolation of staph aureus is not required to make a diagnosis as long as the clinical criteria are already met. Okay? And serologic or skin tests are not deemed practical in the management of the illness. And the determination of subgroups based on susceptibility is more of for epidemiological purposes only. Okay. Now for the treatment, most boils and superficial staph abscesses, they actually resolve spontaneously without antimicrobial therapy or antibiotics, no? And incision and drainage, or IND, is often enough for skin abscesses. Okay, but those that are more serious, more extensive, deeper, or those that involve vital organs, they may require a combination of surgical drainage and antibiotics, no, for the best outcome. Now, antibiotic treatment for Staph aureus has now become quite a challenge. This is because the drugs cannot act in the central necrotic part of a suppurative or lesion with pus. And around 90 to 95% of Staph aureus strains are now resistant to penicillin G. This is because most of these strains produce beta-lactamase or penicillinase. Okay, so what we can use then are beta-lactamase resistant penicillins. No, example: nafcillin, cloxacillin, oxacillin, or dicloxacillin, and some cephalosporins and vancomycin. A penicillin can also be given with another drug for a synergistic effect. No, for example, clavulanic acid is added with amoxicillin to make coamoxiclav. No, you can use this for non-life-threatening skin and soft tissue infections. There are also strains that are resistant to methicillin. No, that's why they are called MRSA, or methicillin-resistant Staphylococcus aureus. This happens to around 20% of cases. And some strains have also developed some resistance to nafcillin, which is actually independent of beta-lactamase production. So the main alternatives for MRSA are vancomycin and daptomycin for deep-seated infections, no? For example, endocarditis, osteomyelitis, bacteremia, and pneumonia. And clindamycin and doxycycline, no, can also be used for superficial skin and soft tissue infections. Bacteremia, endocarditis, pneumonia, and other severe infections caused by Staph aureus require prolonged IV or intravenous treatment. Okay? IV treatment with a beta-lactamase resistant penicillin. Usually, vancomycin is the drug used for intravenous treatment. But other alternatives include newer antibiotics like daptomycin, linezolid, and quinopristine, dalfopristine. It may also be necessary to give two different drugs in combination to lessen the development of drug resistance. Now, worst case scenario, we now have vancomycin resistant Staph aureus, or the VRSA, and the vancomycin intermediate Staph aureus, or the VISA. Now, these strains are typically methicillin and nafcillin resistant as well, which makes them very difficult to treat. So, quinopristine, dalfopristine is the last drug of choice. But fortunately, these strains are very rare for now. Hopefully, they stay rare, no? So, as you can see, choosing the correct drug to treat staphylococcal infections is highly dependent on culture and sensitivity testing, no, or the susceptibility testing of the isolates. The treatment of toxic shock syndrome involves correction of the shock with fluids, pressor drugs, and inotropic drugs to increase and keep the blood pressure up. Okay, and of course, administration of a beta-lactamase resistant penicillin. And yes, removal of the tampon or debridement of the infected site. Because humans are the principal reservoir of Staphylococcus aureus, there will always probably be carriers and infections, no? So it is difficult to block the colonization in the human body, but we can minimize the opportunity for transmission by careful hygiene, okay, to prevent infection. Okay, so frequent hand washing, aseptic technique, and adequate cleansing of wounds, surgical incisions and burns, no, included, especially in the hospital setting where the risk is even higher. Now we go to the coagulase negative staphylococci. So other than Staph aureus, there are more than 45 other staphylococci. No? In medical practice, the less than 20 species that have been isolated from human infections are typically lumped together by a negative characteristic, which is failure to produce coagulase. Now, these coagulase negative staph or cons also do not produce alpha toxin, exfoliatin, or any of the staph superantigen toxins. But they have been shown to have surface adhesins and the ability to produce extracellular polysaccharide biofilms. By far, the most common cons species isolated from human infections are Staph epidermidis and Staph saprophyticus. Okay? Staphylococcus epidermidis and many other species of cons are normal commensals of the skin, also of the anterior nares and ear canals of humans. Okay? Supposedly, in the past, they were rarely the cause of significant infections. But with the increase in the use of indwelling catheters and prosthetic devices, they have become important agents of hospital-acquired infections, no? Particularly in immunosuppressed patients. So, Staph epidermidis is coagulase negative. It does not ferment mannitol. It is non-hemolytic. Okay? On culture, colonies produce gray to white pigment, no? Because remember, they do not produce the staphyloxanthin that makes the Staph aureus golden. Okay? It is the most frequent organism isolated from infected indwelling prosthetic devices, no? For example, orthopedic prosthetics and cardiovascular, particularly prosthetic valves, no? And even pacemakers. Okay? Now, Staphylococcus saprophyticus is typically non-pigmented also. It is novobiocin resistant, and that sets it apart from other coagulase negative staphylococci. It is also non-hemolytic and, of course, coagulase negative. Now, Staph saprophyticus is the second leading cause of urinary tract infections, in sexually active young women. The first is E. coli. And it is mostly commonly acquired by females in the community. That's why in other sources it says it is a common cause of UTI in promiscuous women. Okay, so in summary, staphylococci can be tested for coagulase. So coagulase positive is Staph aureus. If coagulase negative, we can do novobiocin sensitivity. Staphylococcus epidermidis are novobiocin sensitive, and Staph saprophyticus are novobiocin resistant.